Good evening, dear brothers and sisters. I'm very happy to connect with you for our fifth masterclass webinar series on hypertension. As all of you know, this webinar is supported by World Lung Foundation, South Asia, and Mr. Sanjay is also here with us. We are very happy and welcome him. The World Lung Foundation, South Asia's major aims and objectives include the areas of public health ranging from cardiovascular disease control and prevention to road safety to environmental health to civil registration and vital statistics. All public health related activities and the scope of the work cover comprehensive public health service. Of course, whole medical academy, our main aim is to disperse knowledge, and we had been doing a lot of webinars. So we are all very proud to associate with the World Lung Foundation and run this wonderful masterclass webinar series on hypertension. The objectives of this webinar is to promote standardized care for hypertension that is evidence-based and aligned with international best practices. The focus of the virtual workshop would be to promote standardized care for hypertension based on recent WHO hypertension treatment guidelines, to promote opportunistic screening of all patients over the age of 18. We had been in every webinar, we are insisting the private sector also should be involved in opportunity screening whenever somebody comes for any ailment, whether it is a little finger pain or headache or stomach pain or running nose. You will have to check the blood pressure of the patient as well as the patient attendant. So that will give an opportunity for screening. And again, the reduce physicians' inertia to start and continue treatment of hypertension. So this also we discussed in a length, physicians' inertia, to emphasize the importance of medication titration and follow-up. Last week we had adherence, concordance, and follow-up last week. Hypertensive patients to ensure better blood pressure control. These were the 5 webinars which we had conducted. We started the first webinar with our star speaker Chennappan. Today is the 5th webinar. Again, our beloved teacher of teachers Chennappan is there to talk to us on hypertension and diabetes. Dr. Chennappan, the cardiologist, is the speaker. Dr. Rajshekhar, my good brother, is the panelist today. Chennappan needs no introduction, but still is a consultant cardiologist, Ramakrishna Medical Center, Trichy, Emeritus Professor, Tamil Nadu MGR Medical University, Honorary Professor of IMA CGP, former member Board of Studies, Bharathidasan University, Trichy, Honorary Director of Medical Education, Apollo Specialty Hospital, Trichy, Distinguished Clinical Teacher, Apollo Hospitals Education Research Foundation, Faculty Speed Medical Coaching Center, Chennai, Resource Person for Public Health Foundation of India, Advisory Board Member, Journal of Association of India, Managing Trustee, ECG and Echo Club of Trichy. He has received numerous awards: Best Doctor Award 2019 by Government of Tamil Nadu, Best Doctor Award by 2011 by MGR University, Best Doctor Award by Tamil Nadu IMA Chapter, Best Doctor Award by Tamil Nadu Medical Council, Special Appreciation Award by API, Epicon 2014, MG Garg All-Time Achievement Award for the year 2013-14, Vocational Excellence Award 2015 by Rotary, Master Teacher Award 2016, Revered Teacher Award, East Zone Epicon 2017. He had got so many awards, but the best award what he has received is he has touched all the postgraduate students and physicians by his wonderful teaching for the last 4 decades. And now Rajshekhar, of course, most of you know, is the past president of the ACP, past governing council member of API, editor of mnemonics book, 3 editions have come out, monogram on anemia, sub-editor of the Progress in Medicine, and he's also assistant editor of MediBeats, delivered many talks in state and national international conference, written more than 100 articles in Medicine Update, and he is very well known as a WhatsApp professor. Every day he engages at least 12 WhatsApp groups in the morning. All of you know about Kahoot. Those of you who joined recently, please type Kahoot in your laptop or mobile. Download and be ready, and we will give you a game pin number. You have to enter the pin and your name, then you can play. There are 12 questions today. Each question we are giving 20 seconds. Those who give correct answer early will get more marks. With this, I think I request now our beloved Chenyipan to take over and present his presentation on diabetes and hypertension. And after his talk, we'll have Kahoot and then we'll have discussion. Now I request Chenyipan to take over and I'll stop sharing now. Please present your slides, Chenyipan. I also have great pleasure in welcoming Sangram Pradhan, who is our panelist always.
Thank you, sir.
Yes, sir.
Thank you. Good evening. Good evening. Thank you, Murunathan, sir. You know that the introduction is very overwhelming, and you know that I'm not against it anyway. So thank you for your kind words, and respected Dr. Rajsekhar, Dr. Sangram, and I thank World Lung Foundation as well as World Medical Academy for giving me this opportunity to talk to you about hypertension, diabetes mellitus. I think many of you heard this lecture for numerous times, because this topic has been going on for the last 2 to 3 decades. And of course, I'm going to repeat some of that again. So I start with this slide. The diabetes plus hypertension is not 1 plus 1. It is 1 plus 1 is 11. So the cardiovascular risk in diabetes and hypertension is not added, it is multiplied. So that's the most important message I want to give before we start the topic. This is my plan. We tell you about the prevalence of hypertension, diabetes, and diabetes and hypertension. We touch upon some pathogenesis. So we look at what is the impact of hypertension on diabetes mellitus and diabetes mellitus on hypertension, how to make the diagnosis, the goals and choices, and give you the takeaways. So the prevalence is, it can be in type 1 or type 2 diabetes mellitus. So as far as the type 1 diabetes mellitus is concerned, there are 2 factors which increases the incidence and prevalence of hypertension. One, increase in age, and the presence of albuminuria. So of course, today we have some more factors regarding the metabolic changes constituting hypertension. But these are the 2 important aspects of diabetes, type 1 diabetes and hypertension: increasing age and the presence of albuminuria. You can see that now microalbuminuria is called as moderate increased albuminuria, 40%, then it goes to 80%, and of course 85% of patients with diabetic nephropathy have hypertension. So to simply make it very simple, hypertension is up to twice as common in diabetics when compared to the general population or non-diabetics. Hypertension is twice common. So basically what is a common soil is the insulin resistance, from which both hypertension and diabetes develop. So in some people, hypertension develops first and subsequently diabetes. And in some people, diabetes develops first and subsequently hypertension. So it is a common soil which can predispose. That's why it is said by the time you diagnose diabetes mellitus, so many of the patients are already having macrovascular disease. So that's why the famous statement is macrovascular disease starts before the onset of diabetes mellitus, or before you diagnose diabetes mellitus. Microvascular disease starts after the diagnosis of diabetes mellitus. So by the time you diagnose diabetes mellitus, 50 to 60% of patients may already have some atherosclerotic heart disease in the form of abnormal lipids, hypertension, hyperinsulinemia, and so on. So we all know that the diabetes may predispose the patient to hypertension. See, we already said it is twice common. But what we may not realize is that the hypertension predisposing to diabetes. So it is not really thought of, because we always talk about diabetes and hypertension. We think of pathophysiological mechanisms which can cause diabetes to hypertension. So if you look at this data, so it is more common for a hypertensive to develop a diabetes rather than a diabetic to develop hypertension. So that's what we must realize. Long-standing hypertension itself may predispose to diabetes mellitus, because they are partners in crime. So from their dawn, which is insulin resistance. So these are the 2 devils from this dawn, which can produce, which can coexist. One can lead on to the other. So unknown fact is that even the risk of developing diabetes is doubled when your BP is more than 130/85, even in non-obese individuals. So that's what I'm trying to say, both are interrelated. So this is a recent study just published on online from JAPI, a very big Indian study looking at the incidence and prevalence of hypertension, not only hypertension, pre-hypertension, as well as diabetes, no diabetes, and patients who are at risk of diabetes mellitus. It just published on online in July 2022. So if you look at the known diabetic, and it also saw the prevalence in various areas of our country, various states of our country. So when you look at the diabetes mellitus as it is, the presence of hypertension is about 58.1%. More than almost alternate people with the diabetes mellitus may have hypertension. So this is highest in Northeast and lowest in Jammu and Kashmir. So this is about the hypertension in diabetes mellitus. When you look at the data of the first time you diagnose diabetes mellitus, how much of those people have hypertension is 41%. So that's what I told you. By the time you diagnose diabetes mellitus, already 41% of patients may have hypertension. Once again, highest in Northeast and lowest in Jammu and Kashmir. So this is a data regarding the diabetes and diabetes, and diabetes and hypertension. So what is the prevalence of hypertension and diabetes? Hypertension, what is the prevalence of diabetes in a patient with a hypertension? So this is a data from Q study from Mohan and JAPI 2007. So very, very interesting data that he compared the various parameters in normotensives and hypertensives. Look at the HbA1c of Indian hypertensives. It is 6.7. So the average HbA1c of Indian hypertensive is already in a diabetic range. That means that the most of the hypertensives may also have the diabetes mellitus. That's why this is a very important diagram to understand that the insulin resistance may lead on to hypertension. Hypertension can lead on to diabetes mellitus, and both can increase insulin resistance, or insulin resistance can produce diabetes mellitus. Then it can go for hypertension. Both can further increase insulin resistance. So this is the triangle you must always realize whenever you talk about hypertension, diabetes mellitus. That's why I appreciate Dr. Muruganathan. He did not give the title as hypertension in diabetes. He gave the title as hypertension and diabetes. So that is a difference. So with this, we come to the next area of my talk, where the pathophysiology of hypertension in type 1 diabetes mellitus and type 2 diabetes mellitus. In type 1 diabetes mellitus, as I told you, it is a predominant diabetic nephropathy. The onset of microalbuminia signals the arrival of hypertension in patients with a type 1 diabetes mellitus. And of course, this, as I told you, there are recently a lot of metabolic causes have been implicated with the onset of or the presence of hypertension type 2 diabetes, type 1 diabetes mellitus. But type 2 diabetes mellitus and hypertension has got complex pathophysiology. As I told you, these two diseases are interrelated. They can produce functional structural changes in various organs. The hypertension not only produces the abnormality in the vessels, but also in the glucose, lipid, and protein metabolisms. It also involves autonomic nervous system. So there are two important recent pathophysiological mechanisms where there is PPAR gamma down regulation and increase in insulin growth factors both contribute to hypertension today. To make it simple, I always think of this diagram, the four main pathophysiological mechanisms of developing hypertension in diabetes mellitus. One is diabetic nephropathy, and second, the most important pathophysiological mechanism is insulin resistance, the volume expansion, and the blood vessel changes, the microvessel, the conduit vessels, and cushion vessels. So these are the four basic mechanisms by which hypertension develops in hypertension. Let us look at diabetic nephropathy. So whenever the patient has got insulin resistance, even in a pre-diabetic state or a diabetes mellitus, two things are happening. Because the renal autoregulation is lost, as you know, because of the abnormal tuberoglomerular feedback, because of excessive reabsorption of glucose and sodium. So this results in significant afferent arterial dilatation. So there is excessive flow into the kidney. Then, of course, there is an excessive increase in renin, and once again, due to the same negative tuberoglomerular feedback. So this increase of renin and angiotensin. The angiotensin 2 is increased not only in the circulation, but also in the tissue level. So it can produce not only vasoconstriction, but also can produce significant anatomical narrowing of the blood vessels. So it also produces efferent arterial constriction. So you have afferent arterial dilatation and efferent arterial constriction. So this significantly increases intraglomerular pressure. So this intraglomerular pressure produces hyperfiltration. Once there is a hyperfiltration, this is not only because of increase in intraglomerular pressure, but because of the abnormal podocytes as well as the selectivity of the glomerular basement membrane thickening. So the hyperfiltration is one mechanism is intraglomerular hypertension, but abnormal podocytes and abnormal basement membrane thickening also contribute to increase hyperfiltration, and the albumin gets excreted. Once the albumin gets excreted, it produces significant damage to the tubules and nephrons. So subsequently, so as the tubules and nephrons are getting damaged, the remaining nephrons start producing hyperfiltration. They get damaged by themselves by hyperfiltration. So subsequently renal injury, which can produce hypertension. So this is the cascade by which diabetic nephropathy can cause hypertension. So once this hypertension is caused, this is going to further aggravate the intraglomerular pressure and further increase hyperventilation. So this becomes a vicious circle by which the hypertension begets diabetic nephropathy and hypertension itself. So the next mechanism is insulin resistance. So this is the most important mechanism. As a single diagram, as you can understand, how many pathways by which insulin resistance can cause hypertension. So insulin resistance due to various factors, as you know, can produce the abnormal metabolic insulin levels. So the insulin levels actually produces abnormal ATP dependent sodium potassium pump, which ultimately results in significant increase in intracellular sodium, subsequently intracellular calcium. This results in increase in contraction of vascular smooth muscle, vasoconstriction. There is a significant, the insulin resistant to the endothelium. So the endothelium produces less nitric oxide, so less vasodilator, more vasoconstriction. And the insulin resistance also increases angiotensin 2, not only produces vasoconstriction, but also, as I told you, increases the smooth muscle hypertrophy and produce anatomical narrowing in the blood vessels, which increases peripheral resistance. Thereby, it can contribute to hypertension. Not only that, the angiotensin also can produce aldosterone, and the excess aldosterone is going to retain sodium and water, which further increases the cardiac output, contributing to hypertension. In addition to all that, the insulin increases unopposed sympathetic activation. There is an imbalance between parasympathetic activity and increased sympathetic activity, which further increases the cardiac output as well as the contractile vascular smooth muscle. So ultimately, all these mechanisms lead on to hypertension. So that's why you can see that here the multiple mechanisms. So you can also just understand how our multiple drugs are acting in mechanism. When you put a calcium channel blocker, it will act against intracellular calcium. When you put ACE inhibitor or statin, it will act against endothelial dysfunction. When you use ACE inhibitor and ARB, it will act against angiotensin. When you give aldosterone antagonist, it will act against aldosterone. When you give a beta blocker, it will act against the sympathetic system. So this slide ultimately gives you how you treat hypertension in diabetes mellitus. So a very interesting mechanism is, especially in obese people, the action of insulin is that it can increase sympathetic activity, as we have seen, but it can also produce vasodilatation, provided the vascular smooth muscle endothelium is responding to insulin. If the vascular endothelium and smooth muscle responding to insulin, it produces vasodilatation. So sympathetic activity trying to increase the pressure, vasodilatation trying to decrease the pressure. So naturally, there is no change in your blood pressure. But what happens in insulin resistance in obesity is that your sympathetic system continues to be stimulated. But what happens is your vascular endothelium and smooth muscle do not respond to insulin now. So because of that, there is no vasodilatation. There is only increase in sympathetic activity. So there is no counteracting factor against the sympathetic activity, which leads on to elevated blood pressure. So this is a direct action of insulin contributing to hypertension. Then, of course, we have many times told you, today, the adipocyte is not the godown of fat, it is a factory, which can produce so many bad substances, except only one good substance, the adiponectin, your angiotensin 2, leptins, all inflammatory factors, free fatty acids, the plasminogen activator inhibitor, all will be contributing to the development of hypertension, obesity itself. Then we come to the volume expansion, which is unrecognized cause of hypertension in diabetes mellitus. So the volume expansion is because of the hyperglycemia. There is a significant increase in glucose excretion. And we have already told you that after advent of SGLT2 inhibitors, we know how the glucose and sodium are reabsorbed in the proximal tubule, and both are reabsorbed. So when glucose and sodium are reabsorbed, many times we have told you, whenever sodium gets reabsorbed, water automatically comes in along with the sodium. So this produces significant volume expansion, which is also contributed by the aldosterone, which retains sodium and water, the insulin itself, and also the salt loading from the patient side and diabetic nephropathy. So all these things significantly produce volume expansion, which can also contribute to hypertension. And the last one is the blood vessel changes themselves. The blood vessels changes in the microvessels and also cushion vessels and also conduit vessels. So basically, when you look at the conduit vessels and the microvessels, it is primarily because of the endothelial dysfunction. Basically, increase in the bad factors like angiotensin 2, endothelin, thromboxane, and decrease in good factors like nitric oxide and prostacyclin, and increase in permeability factors, increase in the addition factors, and increase in growth factors. So all this contribute to significant narrowing of the medium and small arteries, which significantly increases the peripheral resistance, and that contribute to diastolic hypertension. Then the advanced glycation end products is acting on the collagen of the big vessels like aorta, and it is going to destroy the elastin in the aorta. So destroy the aorta elastin. So once the elastin is destroyed in the aorta, the big vessels become very stiff. So because the big vessels become very stiff, they are going to transmit the pulse wave velocity with a great speed to the periphery, and the returning velocity also comes in the systole itself, contributing to your systolic hypertension. So the big vessels reduce compliance. So in addition to that, increase in cardiac output due to volume expansion also is going to contribute to your systolic hypertension. So systolic hypertension is contributed by the stiffening of the aorta as well as the increase in cardiac output of volume expansion. Whereas the diastolic hypertension is contributed by the increase in peripheral resistance. By that, we have told you many mechanisms. There is vasoconstriction, there is a smooth muscle hypertrophy, there is endothelial dysfunction, all also produce anatomical narrowing. So there is a structural and functional change. That's what we have mentioned in the earlier slide of the blood vessels. So please remember, the patient has got liberty to have hypertension independent of diabetes mellitus. Many times when the patient has got hypertension, diabetes mellitus, we always connect with the diabetes mellitus and think the diabetes is contributing to the hypertension. There are a large number of causes of hypertension independent of diabetes in a patient with diabetes and hypertension. So this can be in diabetes, essential hypertension may coexist, isolated systolic hypertension due to age may be coexisting, or recurrent pyelonephritis may contribute to hypertension. Many of our anti-hypertensive drugs may contribute to hypertension, not the diabetes, not the hypertension per se. Anti-hypertensive drugs themselves can contribute to diabetes and hypertension. And of course, which can cause both the conditions which can cause both hypertension and diabetes, the drugs will be glucocorticoids and oral contraceptive pills. And many endocrine disorders can produce the diabetes and hypertension. So we have to always have an important mindset to look for independent causes of hypertension in diabetes. We cannot assume in all hypertension with diabetes mellitus, diabetes is the cause of hypertension. There may be independent cause of hypertension. So many times we miss that, because these drugs may be constituting the diabetes and hypertension and so on. So having seen some important facts on pathophysiology, now we come to this impact of hypertension on diabetes mellitus and impact of diabetes on hypertension. So whenever the hypertension is added on to diabetes mellitus, there is significant increase in cardiovascular disease and also end-stage renal disease. That's what hypertension does to a diabetic. So the hypertension is added on to the diabetic, significant increase in coronary heart disease, stroke, microvascular disease, and also increase in mortality. So this is what the hypertension does to a diabetic. Increase in CVD, and 70 to 80% of patients with diabetes die of cardiovascular disease, which is terribly going to be increased by the associated hypertension. Then we see what is the impact of diabetes on hypertension. So what happens when diabetes is added on to a hypertension? So that's what we are going to see. For example, for a pressure of 140 to 159, that is a grade 1 hypertension. When the patient does not have diabetes mellitus, he is in low risk, by which we mean his chances of developing stroke or myocardial infarction in next 10 years is less than 15%. But when the patient has got diabetes for the same number of 140 to 160 or 90 to 100, he becomes a high risk. For the same number, the diabetes is added on, or diabetes is superimposed on grade 1 hypertension. The risk of developing the next 10 years myocardial infarction and stroke is 30%. So when diabetes is added on to hypertension, your vascular risk is doubled. When hypertension is added on to diabetes mellitus, once again, your risks are increased. So in both ways, it is bad. Whether a hypertensive becoming a diabetic or diabetic becoming a hypertensive. So that's why it is very, very important to realize the impact of both these diseases on one another. Then, of course, we come to the diagnosis. So diagnosis, I'm not going to say because this is the slide we have shown you many, many times. So very important fact is the correct technique. We have told you three things. One is the patient preparation. Second is the equipment preparation. And third is the right performance by the physician. So all three things are necessary to get the correct BP recording. But in addition to the standard sitting blood pressure in the clinic, we must always look at the postal hypotension or the postal hypertension in a patient with diabetes mellitus, postprandial hypotension in patients with diabetes mellitus. Many of the patients may be complaining of severe tiredness or sleepiness immediately after food. Many times people say, I have to sleep for 2 to 3 hours. I become so drowsy after taking food. In those patients, we must take a postprandial blood pressure, which can be taken up to 2 hours, and the reduction of equal or more than 20 millimeters of systolic is contributing to postprandial hypotension, which is the same pathophysiology as postal hypotension. In both, the compensatory sympathetic mechanisms are not working. And of course, today's treatment and the diagnosis of hypertension is not based on clinic blood pressure alone. You must have an idea about the out-of-clinic blood pressure, like home BP monitoring, as well as ambulatory BP monitoring. And the most important investigations you must do will be, in addition to glucose, the CBC, the lipid profile is very, very important, and serum creatinine with the eGFR, sodium, potassium, and calcium, the thyroid function test we should never forget. A simple urine analysis will give a lot of information. And of course, electrocardiogram. Although the previous guidelines said these three things are optional, I don't think these three things are optional now. So it's also included as a basic investigation in a patient with a diabetes and hypertension, for that matter, any hypertensive. So it is echocardiogram, uric acid, and the most important in diabetes will be urine albumin to creatinine ratio. See, these are the basic investigations which will help us not only plan a particular management and also select an appropriate drugs for that patient who has got hypertension and diabetes mellitus, so that we can reduce or stop the future cardiovascular disease. So these are the basic investigation you must do. And of course, the ambulatory BP monitoring, many times I have told you that it should be done at least once in a year in a patient with a hypertensive, be it whether he's a diabetic or not. At least once in a year, we must have an idea about the 24 hours monitoring. So the most important factor in a diabetic is most of these patients may have well controlled the daytime blood pressure, but they are supposed to dip their blood pressure to the tune of 10 to 20% when compared to the daytime blood pressure. So the people are not dipping less than more than 10% is called they are dipping less than 10% are called the non-dippers, or the blood pressure increasing in the night is called nocturnal hypertension. In all these people, the non-dipper and reverse dippers are the ones who are supposed to develop the future left ventricular hypertrophy, albuminuria, and also retinopathy. So we will be in the false hope of that the patient is doing well by looking at only the daytime blood pressure. For the identical daytime blood pressure, if the patient is not dipping his blood pressure in the night, he is at risk of developing future end organ disease and cardiovascular disease. So that's why it is very important to look at the nighttime blood pressure. So this is the problem in hypertension. So we have got a lot of confusion. What is hypertension, diabetes mellitus? What is the number or threshold by which we can say that this is hypertension, diabetes mellitus? Because once again, many guidelines have confused us. Some guidelines said 140/90, some guidelines said 130/80. So this is a practical thing I told you in the first class itself, or the first lecture itself. So whenever the patient has got risk factor like diabetes, CKD, or coronary heart disease, or heart failure, or increased atherosclerotic cardiovascular risk, the threshold of starting antihypertensive treatment is 130/80, especially when the patient is less than 65 years. The patient is above 65 years and is very active and independent and is able to tolerate medications, you can start at 130/80. For example, even the patient is less than 65 years, the patient is very weak, frail, and has got multiple comorbidities, and is post-stroke patient, and is a low-risk patient, then the threshold of starting antihypertensive treatment will be 140/90, although he is a diabetic. And of course, above 80 years, the threshold of starting will be 150/90. So although we look at the chronological age, it is very, very important. Look at the biological age to decide about the threshold or the definition of hypertension in diabetes mellitus. So it is not a single number for everybody. So the number changes according to the age, according to the risk factors, and according to the pre-existing disease conditions. And of course, the target is going to be less than 130/80 in majority of diabetics. And of course, it should not be less than 120/70. So we have to keep the blood pressure between 120/70 to 130/80. That should be the aim of blood pressure. Of course, the blood pressure target is little lenient when the patient is more than 65 years, or even if he's less than 65 years, if he's so frail and has got multiple comorbid conditions. And it's very important, not only about knowing the target, but the time frame with which you have to achieve the target. You have to achieve the target within 3 months of starting antihypertensive medications. Then we come to the goals. Having diagnosed hypertension, we come to the goals. What is our goal in treatment of hypertension in diabetes? So there are factors which influences the goals. It's once again a moving scenario. Just like I told you, the diagnosed hypertension is a moving scenario. It's not a single number for everybody. Similarly, the goals, that the number you have to achieve in a particular patient is not the same number for everybody. So the factors which are going to influence are the presence of nephropathy, coronary heart disease, elevated dysfunctional heart failure, and other risk factors, in which condition we may need an aggressive control of blood pressure. I just talk about the nephropathy and importance of controlling hypertension, especially systolic hypertension in a diabetic. So this is some example here. The lower levels of blood pressure result in slower rates of decline in renal function. That's the most important message. To give you an example, someone 50 years of age with a GFR 50 ml per minute and systolic blood pressure of 144 will be on dialysis 8 years earlier when compared to the patient who has got the same age and the same GFR, but systolic blood pressure of 134. Simply to say that reduction of 10 millimeters of systolic blood pressure will postpone dialysis by 8 years. So that is the importance of controlling systolic blood pressure in a patient with diabetes mellitus. So that's why we have to give a lot of importance to the systolic blood pressure in a patient with diabetes mellitus. So this is the up-to-date goal of blood pressure in a patient with diabetes mellitus. So in high-risk population where the diabetes mellitus also comes in, the routine or conventional clinic blood pressure goal will be systolic of 125 to 130 bar less than 80 of diastolic. So this is your goal of blood pressure in a patient with a diabetes mellitus at clinic. When you look at the out of clinic blood pressure, like your daytime ambulatory BP monitoring or the home blood pressure, it will be the systolic of 120 to 125 of diastolic of less than 80. So this is your goal you are supposed to achieve in almost all patients of the diabetic patients who have hypertension. So this is the goal of blood pressure. And of course, when the patient is lower risk, when he does not have any one of these the risk factors, then his goal may be 130 to 139 systolic and less than 90 the diastolic when the patient is at clinic and you are measuring blood pressure in the clinic. Whereas when you come out of clinic, the out of clinic, the goal will be 125 to 135 systolic and less than 90 diastolic. So now it's once again a moving target. So the goal is not the same for everybody. It all depends upon whether the influencing factors are there, like diabetic nephropathy or coronary heart disease or LV dysfunction, or you have the high risk population or a low risk population, and where you are measuring the blood pressure, whether you are measuring the blood pressure at clinic, whether you are measuring the blood pressure out of clinic. So everything is not a constant number, a constant scenario in diabetes and hypertension. So having known the goals, what are the choices of drugs we must use to get these goals? The choices are, before we go to the choices, the first and most important choice is the lifestyle modification. So without lifestyle modification, you cannot go to pharmacotherapy. So the weight loss, a very important realization is that if you reduce 1 kg weight, you reduce 1 millimeter of mercury systolic blood pressure. And the 5 kg risk, the weight reduction will reduce systolic blood pressure of 5 millimeters of mercury. Even in normotension, you can reduce blood pressure. When you have the dietary advice to stop hypertension, which is rich in fruits, vegetables, whole grains, and low fat, and decreased saturated fat, you can see the amount of blood pressure reduction. This is not even achieved by some of the drugs. The 2-digit blood pressure reduction of 11 millimeter blood pressure reduction and also 3 millimeter blood pressure reduction when the patient is normotensive. When the dietary sodium is less than 1,500 milligram per day, which translates into 1 teaspoon of salt per day, will reduce the blood pressure by 5 to 6 millimeters of mercury. By increasing the dietary potassium, not the chemical potassium, by increasing the dietary potassium, by which we mean a lot of fruits, vegetables, and greens, which are rich in potassium. If you increase your dietary potassium, you can reduce by 4 millimeters of mercury. The aerobic exercise, at least 30 minutes per day, will reduce 5 to 8. And of course, today, we have 2 more forms of exercise in the form of dynamic resistance exercise and isometric resistance exercise in diabetes and hypertension only, but not in patients with additional heart disease. These 2 exercises should not be employed in patients with additional heart disease, like coronary heart disease or heart failure. When a pure diabetes and hypertension exists, then of course, these 2 exercises, dynamic resistance exercise and isometric exercises, also can reduce the blood pressure, as well as they can give you the metabolic benefit. This will also help you to control your diabetes and also the lipids. And of course, the moderation in alcohol intake will also reduce 4 millimeters of mercury. So it doesn't mean that we must ask a non-drinker to drink alcohol to reduce the blood pressure. Non-drinker remains a non-drinker. If the patient is drinking alcohol, then the drink should come down to less than 2 drinks in men and less than 1 drink in women. So without these the basic lifestyle modification, we call them today as TLC. They are therapeutic lifestyle changes. The lifestyle changes is not lifestyle changes. They are therapeutics. They are therapeutics like your drugs. That's why they are called therapeutic lifestyle changes. So what is expected of an antihypertensive drug in a diabetes mellitus? So first of all, it has to get the right number for that right patient. So it has to reduce long-term cardiovascular and renal events. It should not increase sugars. It should not increase your metabolic factors like lipids and uric acids and so on. It must also produce weight reduction and should not increase the weight. It should not worsen coexisting medical conditions like CKD or the risk factors like your lipids and so on. And many times the patient may need multiple drugs, so it should be easily combined with other drugs. And the side effect should be minimum. And the most important factor in our country will be the cost. So this is the ideal antihypertensive drug. Unfortunately, today we don't have a drug which will actually satisfy all of these conditions in antihypertensive therapeutics. So first we come to the most important drug of renin-angiotensin-aldosterone system, which is actually a factor, the RAS activation. I told you about the 4 important mechanisms of hypertension, and the RAS activation is going to produce all these 4 mechanisms to produce hypertension. It is going to produce, we already seen how it produces efferent arterial constriction to produce the intraglomerular hypertension, and it can produce insulin resistance. And by aldosterone, it will expands the volume. By the vasoconstriction and smooth muscle hypertrophy, it will already seen that the angiotensin can produce the blood vessel changes. So the blocking the aldosterone system, renin-angiotensin-aldosterone system, is a most important mechanism by which we can reduce blood pressure in a patient with diabetes mellitus. That's why we have the trials, huge trials on AC inhibitors as well as ARBs, primarily on the control of hypertension as well as preventing future renal problems. So the AC inhibitors can reduce decline in GFR and the amount of albuminuria. It can reduce proteinuria. And of course, this is the most important thing is it can reduce the progression from non-albuminuria to the microalbuminuria, to a macroalbuminuria. So they are very important drugs, so similar trials are there for receptor blockers. So these are the first line drugs whenever the patient has got proteinuria. So that's why many guidelines today start saying diabetes and hypertension, first important thing is whether the patient has got proteinuria or not. The proteinuria is there, you have to start with either AC inhibitor or ARB. How to select between them? So the patient has got additional heart disease like coronary heart disease or heart failure or asymptomatic LV dysfunction. AC inhibitors are the first drugs of choice when the patient has got additional heart disease. So between them, as a cardiologist, we prefer AC inhibitors over the ARBs. So the MicroHope study, which is primarily was looking at, the MicroHope actually was looking at whether the AC inhibitors are going to retard the progression from non-albuminuria to the microalbuminuria. But what are the results we had in MicroHope? In addition to kidney protection, they reduce total mortality, they reduce cardiovascular mortality, they reduce non-fatal MI and stroke. This is the ramipril. So the AC inhibitors, especially in diabetes and hypertension, so not only is going to protect your kidney, but also it is going to protect your heart by means of reducing all these cardiovascular events. So that's why they become the most important drugs in the control of hypertension in patients with diabetes mellitus. So what is very important to realize is the benefits offered by AC inhibitors to a diabetic is more than the benefit offered to a non-diabetic. So that is an important thing to realize. That's why it's a very, very important to use these drugs in patients with hypertension, diabetes mellitus. So the question comes, what AC inhibitor in diabetes mellitus? So there are large amount of data for ramipril. We can also use perindopril, but the first drug we prefer will be ramipril. What ARB to be used in diabetes and hypertension? It is telmisartan because of 2 things. All the other ARBs will be blocking the angiotensin 81 receptor and reduce the action of angiotensin 2 on variety of situations. But telmisartan has got an additional benefit of activating PPAR gamma pathways, by which it can reduce the insulin resistance, it can favorably alter the dyslipidemia, and it can reduce inflammation. So there is an additional benefit of using telmisartan in patients with diabetes mellitus because of this activation. This is peculiar to telmisartan. That's why telmisartan is called bifunctional or bimodal ARB in patients with diabetes mellitus. So that's why if at all you have to use the ARBs in hypertension and diabetes mellitus, we prefer to use telmisartan because it is not only going to control blood pressure, it is also going to give you very important advantage of other lipids parameters and insulin resistance, thereby ultimately reducing the vascular atherosclerosis and thereby giving you vascular protection. In a pre-diabetic state like the metabolic syndrome, what drug to be given to prevent future diabetes mellitus? Patient is in a pre-diabetic state and he should not develop not only diabetes but also hypertension. So what is the drug for a hypertensive? I told you, hypertensive patient may be getting diabetes subsequently because we showed you the data. So if the patient is a hypertensive and you want to prevent a diabetic in that patient, for example, patient is obese and the patient has got a very strong family history of diabetes mellitus, you have multiple high risk for developing future diabetes mellitus in a hypertensive. It is always ARBs and ACE inhibitors, which are the best drugs to prevent new onset of diabetes mellitus in a patient with hypertension. So this is how we prevent diabetes in hypertension patients. Of course, the least will be the diuretics and beta blockers. And we come to the next group of drugs, which are beta blockers. So whenever there is, we already seen the insulin resistance will increase sympathetic activity. Whenever you have increase in sympathetic activity, there is going to be some ventricular arrhythmias, there is going to be ischemic heart disease, and it's going to be the high blood pressure with a non-dipping pattern, and you are going to have nephropathy, and you have also the plasma renin aldosterone, and which will increase the angiotensin. So it is not, it can see that the increase in sympathetic activity is very bad, not only for the heart, not only for the kidney, but also to the metabolic problem, metabolic tissues. So that's why it is very, very important to block the beta norepinephrine beta or sympathetic system by the beta blockade. So that's why it is very important to realize that withholding beta blockers in diabetes in situations like coronary heart disease, post-MI, LV dysfunction, and tachyarrhythmias and heart failure will double the mortality risk in a diabetic. So that's an important thing to realize. In these situations, the patient should be on a beta blocker. So whenever there is enhanced sympathetic activity in the form of sinus tachycardia, sweating, and also increased heart rate response on exercise, you must put the patient on the beta blockers. So the best beta blocker in a diabetic is carvedilol, because it's the only beta blocker which can actually increase the insulin sensitivity, and the bisoprolol may not produce increase in glucose or significant masking of hypoglycemia. And of course, the last one is nebivolol. So these are the beta blockers we prefer in a patient with diabetes and hypertension. Then the diuretics come next, and the practical implication will be the best indication for a diuretic is an isolated systolic hypertension. You start with a low dose, preferably most often the diuretics, except in isolated systolic hypertension, will be an add-on drug, best added on with the ACE inhibitor and ARB. And it should not be combined as the initial combination in a diabetic and hypertensive. Beta blocker plus diuretic should not be the initial combination. So it should be avoided in a patient who has got a history of non-ketotic osmolar coma, hyperosmolar coma, and of course, thiazide if the creatinine is less, loop diuretic if there is a significant renal damage. The best diuretic in a diabetic is indapamide, which does not have a metabolic consequences. In resistant hypertension, of course, we have to go to aldosterone antagonists like spironolactone. Then comes the calcium channel blockers. Once again, they behave as a best add-on drugs. So the calcium channel blockers may not be the initial drugs in a patient with diabetes and hypertension, especially when the patient has got proteinuria. So this should not be the initial drug like amlodipine. And of course, today we have benidipine, which has got some better effect than amlodipine. But the first and best drug will be amlodipine because of the clinical trial evidence of reducing future clinical events. And of course, benidipine will beautifully combine with the ACE inhibitor and ARB to reduce the proteinuria and prevent further renal damage, because it can dilate, it can constrict afferent arteriolar and dilate efferent arteriole, thereby reducing the intraglomerular pressure. And of course, if at all you have to use the calcium channel blocker in a patient with proteinuria, it has to be very high dose verapamil and diltiazem, which are dihydropyridine calcium channel blockers, provided the patient has got normal left ventricular function. So among all this, so we have told about the individual drugs, what will be the best combination in a diabetic and hypertensive. The best combination will be the combination of calcium channel blocker plus AC inhibitor or an ARB. So because both the drugs will have a powerful BP lowering and getting the target, and of course, both the drugs, especially the RAS plus drugs like benedipine, may slow the progression of renal disease. And that's why, and of course, the drugs like AC inhibitors with the calcium channel blockers, the AC inhibitors also can give you the better benefit on the cardiac side. That's why it's the best combination. Although there's a lot of confusion about how to go about treating, because today's recommendation is to start a dual low dose combination in the first stage itself. Then how are we going to start in a patient with diabetes? This is a practical point I'm saying. This may not be in any guideline. This is our own way of thinking of going and applying the latest guideline to a patient with the diabetes and hypertension. So first of all, in any hypertension and diabetes patient, the goal should be less than 130/80. In majority of patients, the target at which you start antihypertensive therapy will be 130/80. So look at coronary heart disease, LV dysfunction, heart failure, or tachyarrhythmia. If these four things are absent, start with a low dose angiotensin inhibitor like ACE inhibitor or ARB plus a calcium channel blocker. The low dose is the half of target dose. So BP is not under control, then of course go to the target dose, full dose of angiotensin inhibitor plus calcium channel blocker. Still it is not under control, then add a diuretic. Along with this diuretic should be indapamide, calcium channel blocker should be amlodipine or benedipine. And of course, angiotensin inhibitor may be, as we prefer, ACE inhibitor or an ARB here. Then of course, when the patient is not under control, he goes for apparent resistant hypertension. We come to this side. If any one of these things are present, start with A plus B. That is angiotensin inhibitor plus a beta blocker. The beta blocker can be a carvedilol, bisoprolol, or a nebivolol rarely. Low dose. Please remember here, even though the pressure is under control, you have to go to the target dose in this situation. So that's a very important thing to realize, that the patient has got a coronary heart disease. He must be on a maximal tolerated dose of angiotensin inhibitor plus beta blocker. What is this angiotensin inhibitor? When the patient has got any of these things, it will be ramipril. So it will be ramipril will be plus carvedilol will be the best combination here. Low dose and check the blood pressure. Blood pressure is normal or still high. Even though it is normal, try to go to the maximum tolerated dose. And of course, third step will be always a diuretic indapamide here. So in both these situations, the patient on 3 drugs, including a diuretic, not a target, he will go for apparent resistant hypertension. Then of course, you rule out the pseudo-resistant causes like the poor technique, the pseudo-hypertension of elderly, physician's inertia, white coat hypertension, the drug-related problem, patient's complaint and adherence. When you rule out the pseudo-resistant causes, the patient comes to 2 resistant hypertension. So what is the 4th drug you are going to add? For that, you have to look at the heart rate and potassium. If the heart rate is more than 70, then add a beta blocker. If your potassium less than 4.5, add a spironolactone. If the heart rate is more than 70, you cannot use a beta blocker, or in spite of a beta blocker, the heart rate is more than 70, add a clonidine. If his heart rate is less than 70 and the potassium is more than 4.5, not 45, 4.5, it is an alpha blocker. So this is the 4th drug you can add when the patient goes for resistant hypertension. So this is a practical thing, I think, by actually following the guideline where they started advocating the combination of 2 low dose combinations, and depending upon here whether the patient is on albuminuria or not is definitely is indicated. People start, the recommendations are with albuminuria is there, angiotensin inhibitor or ARB, AC inhibitor or ARB. When albuminuria is not present, any one of the antihypertensive drugs. This is how the guidelines start. But the recent guideline says that dual drug in a low dose combination. So that's why we have come out this algorithm of practically treating hypertension in patients with diabetes mellitus. So how to treat diabetes when the patient has got hypertension? What are the drugs you want to give for the treatment of diabetes mellitus? Now we have drugs which can also decrease the blood pressure. Anti-hypergenic agent which can raise the blood pressure. The best thing will be empagliflozin. We can say it can reduce the BP change up to 4 millimeters of mercury systolic. And of course, the canagliflozin. Then GLP-1 receptor analogs, GLP-1 GLP-1 also can give you some amount of BP reduction. So now we can show that what drug we have to change on the diabetic side when the patient has got hypertension or heart disease. So with this, I come to the takeaways that when you look at the pathophysiological mechanisms and the treatment, diabetic nephropathy is best treated by detecting the albumin at the earliest. The BP control is very, very important. Best drug will be AC inhibitor, ARB. Insulin resistance is treated by the AC inhibitor, statins, and carvedilol. And volume expansion is treated with the diuretic, and the diuretic of indapamide or intestinal hypertension aldosterone inhibitor. Blood vessel changes, reversing microvascular or the medium-sized changes with AC inhibitors and statins. And of course, large vessel compliance can be done by the sugar control, AC inhibitor plus calcium channel blocker, or the drugs of choice for to reduce the resistance or increase the elasticity of the aorta will be the AC inhibitor plus calcium channel blocker. So you have some idea. So what is the pathophysiological mechanism and what drug we are using according to the pathophysiological mechanism? So the most important message I want to give you is this, another part of the article published by the Nagaratna Raghuram in our JP July. So it is very important to realize, even when the patient is pre-diabetic patient, HbA1c of 5.7 to 6.4, the incidence, one third of them already have hypertension. In a pre-diabetes, one third of them have hypertension. In pre-diabetes, almost more than half of them have got high normal blood pressure, previously had pre-hypertension. That is, the pre-diabetes plus pre-hypertension is the population we have to concentrate on, not a patient with a hypertension and diabetes mellitus. Because this is the patient population where by your effective intervention, you can prevent both diabetes and hypertension. So that is about the 57.3% of pre-diabetics are supposed to have pre-hypertension, and 35% of patients are supposed to have hypertension by itself in a pre-diabetes. So when you come to a patient who is at a high risk of diabetes, he is not a pre-diabetes, but high risk of diabetes with high IDR score, you can look at the pre-hypertension is 58.1%. So even though the patient has not developed diabetes, even though the patient has not developed pre-diabetes, when he's at risk of diabetes itself, the hypertension is 1/4 here. And of course, the pre-diabetes is 58.1% here. So this is the population we have to concentrate, where we have to concentrate on high risk of diabetes and the pre-diabetes and high normal blood pressure patients, so that here we have the huge window of opportunity to prevent both these diseases. So our message is not only concentrating on getting the hypertension control in a diabetic, but also preventing diabetes as well as hypertension by giving our attention to a patient with a pre-diabetes, a patient with a high risk of diabetes, and a patient with a high normal blood pressure. So the Indian saying is, by the time you diagnose diabetes mellitus, most often hypertension is already there. By the time you diagnose hypertension, many of them have got diabetes there. So diabetes pre-diabetes hypertension, hypertension pre-diabetes diabetes. So that's why concentrate on pre-diabetes, high risk for diabetes, and high normal blood pressure. In these are the patients we have to concentrate on to prevent both diabetes and hypertension in our Indian population, thereby preventing future cardiovascular disease. A huge population is there with diabetes and hypertension, and huge population is waiting to become diabetics and hypertensives. That's why we have told you this important message of concentrating on pre-diabetic patients, high risk of diabetic patients, and also the high normal blood pressure. Once the patient has got hypertension, established hypertension, diabetes mellitus, select drugs appropriate to the pathophysiological mechanisms, achieve the targets and maintain the target. And of course, we told you about the prevention. Intervention like lifestyle changes, therapeutic lifestyle changes and appropriate drugs will prevent future diabetes mellitus, hypertension, cardiovascular disease. So in diabetes and hypertension, the important message I want to give will be the predict diabetes in hypertension and hypertension and diabetic. Predict them and prevent them from developing diabetes and hypertension, and of course protect our Indian population by acting early and acting correctly and acting aggressively. Thank you for your patience.
Thank you very much, Chenipan. As everybody has said, another wonderful lecture by Chenipan. There is no wonder how we can, deliver. Again and again, he had given this diabetic hypertension. So every time, he gives some new angle and new point. Now we'll go to the Kahoot. Before we go for the discussion, be ready with the Kahoot app. We'll start the Kahoot now. Okay, please be ready. I'll give the game pin, and game pin is 313-5258. We have got 12 questions, 20 seconds each for the question. 313-5258. I think Mega has taken the account of all the delegates who attended all the 5 webinars who had participated in Kahoot. I request those of you who have attended all the 5 webinars and those of you who have attended all the 5 Kahoots, please send your address, mailing address, courier address to me or to Mega. Mega will give the email ID. Mega, please give the email ID in the chat box. So we'll get the list of attendees who attended all the 5 webinars and who had attended all the 5 Kahoots.
Yes, sir. I'm just sharing with everyone.
Yeah, please send a message and ask them to chat. And so many people are asking for all the 5 webinar links.
Yeah.
So you please, Mega, give the link to everyone so that they can go back and then listen once more.
Sure,
all
sir.
the webinars. Yes.
Yeah.
I'll give you last 5 seconds. We got nearly 200 people now, so I think we should have at least 100 members. Last 3 seconds now. Nadarajan, Somu, all our usual good friends have joined. So I'll start now. Let me count 3, 2, 1. Here is your first question. Hypertension predisposes to diabetes mellitus commonly than diabetes to hypertension. Is the statement true or false? Hypertension predisposed to diabetes commonly than diabetes to hypertension. Is the statement true or false? Very good. 36 have answered. Yeah, Chenipan was saying hypertension predisposes to diabetes more than 2.5 times compared to diabetes only 2 times. Hittu, Sundarabandi, and Rekha. Now the second question, in type 1 diabetes, hypertension is related to insulin resistance, salt intake, mental stress, moderate increased albumin. Diabetic type 1 diabetes, hypertension is related to. He said 2 things. Very good. One is albumin, the other one is age. Hittu, Sundarabandi, Khan. Now the third question. ROS activation causes diabetes by all except angiotensin 2, aldosterone, increased parasympathetic activity, decreased nitric oxide. All except, you must write except. except increased parasympathetic activity. So it is only increased parasympathetic activity is except. It is usually sympathetic activity over Sundarapandi, San and Nihal. The fourth one, in type 2 diabetes, hypertension is because of all below except again volume contraction, insulin resistance, nephropathy, RAS activation. All except. It is volume contraction. Yes, except volume contraction. On the contrary, it is volume expansion. So San, Nihal and Saravanan. The fifth one, which of the following is the most important factor in causing future complications in this toxic combination? Duration of diabetes, non-dipping, lipids or obesity? It is non-dipping. Again, San, Nihal and Saravanan. 56-year-old man, diabetes with CAD, threshold for starting antihypertensive, less than 130/80, more than 140/90, less than 120, more than 120/80 or confusion. More than 130/80 or more than 120/80 or more than 140/90. Super. It is more than 130/80. San, Nihal, Geeta. The seventh question, which BP control postpones dialysis in diabetes hypertensive? Which BP control postpones? He has given an example. Diastolic, systolic, or systolic and diastolic, or all of the above. It is systolic. He said 144 versus 134, where 8 years earlier you developed with 144. The next one, 8. Which of the following is bimodal ARB? Losartan, azilsartan, valsartan, telmisartan. Very good. Telmisartan, both PPR gamma pathway and angiotensin pathway. Telmisartan, Nihal, Geeta, San. The ninth one, in diabetes hypertension, diabetic hypertension, heart failure starting combination should be telmi plus diuretics, carvedilol from rampril, carvedilol amlodipine, CAB with diuretics. It is carvedilol with rampril. Again, Nihal only, Geeta, Rajesh. Now the 10th question. Following combinations should be avoided as initial combination, except beta blocker plus diuretic, calcium channel blocker with diuretic, ACE inhibitor with ARB, beta blocker with ARB, ARB with calcium channel blocker. As an initial combination, all combinations are possible, but as an initial combination. Except, it's except. Yes, ARB with calcium channel blocker is the most ideal combination. You have to start with, preferably if there's no contraindication, with this combination. Nihal, Geeta, San. Then 11th one. Diabetes hypertension patient feels tired after food. What will you do? Check sugar, check electrolytes, check ECG, check BP up to 2 hours, check BP up to 30 minutes. Check BP up to 2 hours, because it's a postprandial hypotension because of the autonomic dysfunction. Even this we discussed in the first webinar also. So make it a point, drive home point. Any diabetic patient with hypertension, if they feel tired, up to 2 hours, you can check. And if the fall in BP is less, around 20, you could diagnose postprandial hypotension. What are the P's of takeaways except pulse of the patient, prevent, predict and protect. Three P's. One P is not there. Chenapan always likes to have humor. He'll say enemy or wife or purse or So today, yes, super. Now we'll see who are the winners now. 11 out of 12, Sai Karthik. 10 out of 12, Jatin. 12 out of 12, super. Nihal Sharif. Let us see who's 4th and 5th. San and Anand. Okay, congratulations for the winners. I'll stop sharing. We'll go to the panelists now. Dr. Rajshekhar.
Yes, sir.
Yeah, your comments, then I'll go for questions. Any comment you want to make? Otherwise, I'll go for a question.
Please go to the questions. He has highlighted very nicely about hypertension and diabetes, the deadly duet.
Okay, fine. Okay, Chenipan.
Yes, sir.
Yeah,
you read the first question.
No. I will go to the. I'll talk first. Then we go to the questions. Chenipan, normally you will have this slide. I think you have missed this slide. I don't know why. What is the peculiar about diabetic hypertension? What are the peculiarities of diabetic hypertension? Normally you have on slide, Chenipan.
Sir?
What is the peculiarity of the diabetic hypertension?
Peculiarities of diabetes. You want to ask about hypertension or diabetes?
Diabetic. I say okay. I will say normally your slide will show the diabetic hypertension. The BP variability is more. Diabetic hypertension, the systolic blood pressure especially is more. Also, they are salt sensitive, and then it is more common in India. So autonomic disturbance is common. So these are 4-5 peculiarities or characteristics of diabetic hypertension. Normally you have the slide. I don't know, this slide is missing in your so that's why I thought I'll bring that point to you.
I have something to leave to say, sir. So I put a slide, you will not have anything to say. So I missed a slide purposefully for you to say that is it is there.
Okay. Another my point, because Chenipan said, I have to give my point. Please believe me, everybody talks about diabetic hypertension means they talk about blood sugar, home blood sugar monitoring. Nobody talks about home blood pressure monitoring. If there is a problem, it is due to hypertension only, not due to diabetes. So whenever you check home blood sugar monitoring, home blood pressure monitoring is also important. Kindly promote home blood pressure monitoring also. You have to control hypertension in a diabetic hypertension more than controlling diabetes. Agreed, Chenipan?
Yes, sir. Definitely. We have already said that today's treatment and diagnosis of hypertension is not based on clinic BP alone.
And is there any role, anything called telomere length and diabetes? There are some correlations between telomere length and hypertension. Any idea?
No, sir. No ideas.
There'll be short telomere in diabetic hypertension, and they have some studies on telomere length. Okay, now I'll go to Rajshekhar. Rajshekhar, please go ahead, Rajshekhar. You wanted to say something. Rajshekhar?
Yes, sir.
You want to say something? Yes.
No, sir. Just questions.
Okay, go ahead. You want to ask questions, Rajshekhar.
In the chat box, there are questions. I'll go through one by one.
Okay, but so before that, Chenipan, this is a study, real length study, where they have discussed age-wise what are the complications with hypertension with dyslipidemia, what are the percentage, hypertension, diabetes, how many percentage, hypertension, diabetes, and dyslipidemia, how many percentage, age-wise. Again, the family history-wise also, they've said hypertension, diabetes, dyslipidemia alone, diabetes and dyslipidemia, diabetes, hypertension, dyslipidemia. So these are another risk factors and comorbidities in young Indian patients with hypertension, real young study. So this gives you what are the comorbidities in hypertension and diabetes and dyslipidemia, just for the completion sake. And also in public health study, we have got Madhya Pradesh treatment protocol in type 2 diabetes, just like hypertension. Even now, for the diabetes, now we have a protocol. Every state has got a protocol. You start with metformin 500 SR, then start with 1000, then 1000 SR BD, add glimepiride 1 milligram, then add glimepiride 2 milligram, then add pioglitazone, and or if there is no control, refer to the specialist. This is again another protocol from the this is Telangana. So they are also saying metformin, and then if there is no target, use glimepiride. So every state has developed a protocol. This is Karnataka protocol. Again, first prescribe metformin 500, metformin SR 1000, then 1000 BD, and then glimepiride 1 milligram, glimepiride 2 milligram. If still not controlled, refer to specialist. See, why I want to say this? Because last time people were asking what the public health are doing, what is the government doing. Now the non-communicable disease in the government of India and state governments, ICMR, WHO, all of them have put together. They've taken a lot of pilot studies in many districts where they give simplified protocols for hypertension. They start with amlodipine, telmisartan, and chlorthalidone. These three drugs mainly. Same way for the diabetes, they give metformin and glimepiride. So just to complete, 24 hours, 365 days, the drugs should be available. These drugs are essential listed drugs, and they give 1 month supply. So continuously non-stop uninterrupted drug supply, which makes hypertension and diabetes under control. Now go to please Rajshekhar, you go ahead with your questions, because you have already seen some questions in the chat box. You can ask the questions.
You have told about the telomere lengthening. Yes, there is a shortening of telomere, especially in diabetes with high ischemic heart disease. It gets aggravated in hypertension. There is a recent article in Indian Heart Journal.
Yeah, that's why I asked that question. Doesn't matter. Rajshekhar, you go ahead with the questions.
Yes, the first question, Chennaipan by Dr. Shyam Sandeep Kumar, role of uric acid in hypertension and diabetes.
The uric acid is a very important factor which can give you a warning about a future heart disease as well as future kidney disease. So that's why we have put it that as one of the important tests, a routine blood test in all hypertensives. So many of your drugs we are using for hypertension may increase uric acid, especially thiazide diuretics may increase the uric acid. So, and also it has got some therapeutic implications on using which drug you have to use when you have a high uric acid and hypertension, because the losartan has got a peculiar property of reducing. There's the only ARB which reduces the uric acid. So, of course, today SGLT2 inhibitors also a very important drugs in the treatment of diabetes, which can reduce uric acid. So it has got a lot of importance, not only about coexisting diseases, future diseases, as well as what drug you have to use in the treatment of hypertension.
Okay, Rajshekhar.
Another question from Dr. Sandeep Kumar. Is there a reverse non-dipping, that is, instead of dropping in night, it increases at midnight, especially in ambulatory blood pressure recording? How to manage?
So this is called nocturnal hypertension, a very, very dangerous disease. The nocturnal hypertension where the BP increases in the night. So that can be identified only by either ambulatory BP monitoring, and also now we have additional facilities in home BP monitoring, which can reduce, record blood pressure in the nights 3 or 4 times without disturbing the patient. And of course, if the patient has got a nocturnal hypertension, so the important thing to see will be the increase in sympathetic activity. So there is a significant. So what happens? Why the dipping is happening is because of the sympathetic activity is withdrawn and parasympathetic activity is coming in. So that's what it produces the dipping. So whenever the sympathetic activity increases, what will happen will be your blood pressure will not drop, or the blood pressure may actually increase. So there is a significant increase in sympathetic activity, which may signal nocturnal hypertension. And the nocturnal hypertension can be also caused by the most important disease called obstructive sleep apnea. So another important cause of hypertension is increase in sympathetic activities, obstructive sleep apnea. So you have to look for obstructive sleep apnea, especially in patients with the nocturnal hypertension. So the nocturnal hypertension, if you are sure and if your heart rate is increasing, and the best study will be not only the ambulatory beat monitoring, but also the sleep study. Today in sleep study, not only we look at the apnea, hypopnea, we look at the heart rate, oxygen saturation, the leg movement. The leg movement is a very important parameter today in a sleep study, which all tells us there is an increase in sympathetic activity. There are a lot of parameters by which you can identify in a sleep study, the sympathetic activity is actually increasing. So in all this happening, is best drug will be to give a beta blocker in the night. So cut down that surge of sympathetic activity, which produces nocturnal hypertension.
Yes, so there are 4 types of dipping. That is normal dipping, extreme dippers, reverse dippers. These are the 4 types. The extreme dippers, again, problem, that is they go in for stroke.
Cerebral problem. Cerebral problem.
Yeah,
Yes.
cerebral stroke problem.
Go ahead.
Yes, sir, please.
Go ahead. Rashid, go ahead.
Regarding the age-wise, they got confused. 65 years, target 140/90, but goal shown 130/80. Final statement for more than 65 years,
Mute.
less than 140 or 130.
Mute.
I told you it's all moving target. So
Yes.
if the patient is
Chenipan, kindly unmute.
So it is what second told you, it is not a single factor which decides. It is a age, coexisting factors, and the pattern or the patient's comorbids and how the patient is. If the patient is less than 65 years, he is active, he is independent, he is well preserved, and he has got multiple risk factors like diabetes, CAD. Your goal is less than 130/80. But the same patient with less than 65 years has got multiple comorbids, frail patient, he is not independent, and he has got multiple problems. Although he is less than 65 years, your goal is less than 140/90.
I welcome. Rashid, yeah, please. Gursan Sidhu.
Good evening. Good evening.
Yeah, welcome, Gursan Sidhu. She's from Ludhiana. Okay. After Rashid, you can ask questions, Chenipan. Meenakshi Bhattacharya, you can also ask questions. Finish your question, Rashid.
Another question from Dr. Sandeep Kumar. Uncontrolled hypertension, patient who is on perindopril 10 mg, amlodipine 10 mg, indapamide 2.5. What will you recommend to increase ACE or CCB or add beta block?
Oh, when the patient has got when you define a resistant hypertension, it means the 3 drugs are on optimal doses. The 3 drugs are not on optimal doses, we cannot say that the patient is in a resistant hypertension. So when you have 3 drugs on optimal doses, only he becomes a resistant hypertension. If the 3 drugs are not on optimal doses, it is a pseudo-resistant cause of pseudo-resistant or apparent resistant hypertension. So when the 3 drugs, that's what I told you, the 4 options in the bottom when I looked at when I presented that algorithm. So when the patient has got resistant hypertension, you are already using the maximum dose of 3 drugs, like indapamide you are using, and you are using AC inhibitor, and you are using the calcium channel blocker. The one thing we can do will be, if the patient has got no cardiac disease, I will try to change the perindopril into an ARB, because ARB will have a better BP control when it comes to the AC inhibitor. So I'll switch over to telmisartan and see whether this patient has got better BP control with switching over to an ARB. But in spite of switching over to ARB, if the patient is not under control, then we look at the heart rate. Then we look at the potassium. So if the heart rate is more than 70, it is preferable to add a beta blocker. If the potassium is in spite of using the maximal dose of AC inhibitor, your potassium is less than 4.5, it means you are hyperaldosteronism. Then you have to use aldosterone antagonists like spironolactone. If your heart rate is more than 70 in spite of a beta blocker, or you cannot use a beta blocker because some contraindication, then the drug of choice, especially with a renal disease, is clonidine. When the patient has got less than 70 and his potassium is more than 4.5, the drug of choice is alpha blocker. So this is some sort of drug selection, especially on the 4th drug. How you select that 4th drug?
Yeah, but in this connection, Rajshekar, Chenipan, now recent studies, of course, this is not connected with us. The Finerenone, which is a good drug, even if their potassium is low, mineralocorticoid, that can be used. And now there are 2 papers, Chenipan. One is SGLT plus Finerenone, and ARNI plus Finerenone. They say it's very good in resistant hypertension. Recently, we have got a paper on this. So Finerenone is coming to India also, and people started using Finerenone. Yeah, go ahead, Rajshekar.
Not only that, Finerenone is a non-steroidal structure. So gynecomastia is uncommon with Finerenone. Another point to be highlighted. Should the ARB or ACE to be given to all patients with diabetes with CKD and no hypertension? Up to what level serum creatinine you can give ARB or ACE, keeping to watch on serum potassium? That you have already highlighted.
This is a very any hypertension talk, we get this question. Every time we answer. So today it is not the single point of creatinine where we cannot give a ACE inhibitor ARB. So it all depends upon how the patient is going to respond from that creatinine level or the potassium level after giving an ACE inhibitor ARB. So the patient may definitely get initial days, definitely the serum creatinine will go up and the definitely little potassium will go up. So the guidelines now come to eGFR, and the eGFR is falling more than 15% after starting ACE inhibitor or ARB, and your potassium is going beyond 5.5. In that patient, you cannot be giving, you cannot give an ACE inhibitor or ARB. If the eGFR is falling, but it is less than 15%, and your potassium is increasing, but slightly increasing, and this is the best patient who will respond to ACE inhibitor and ARB. If nothing is happening, this patient may not respond to ACE inhibitor ARB. So these are the points, especially with the GGF, we have to look at.
Rajshekar, wait a minute. Gurusar Sidhu, please.
I was just listening to this. Can we have an fixed value of an eGFR? Because otherwise, falling means in what time the eGFR falls. You said 15% fall. During what time?
So
normally,
usually,
like we say, if the eGFR is less than 30, to use.
So that in that case, first of all, we may not be using the ACE inhibitor at all in the first phase. So only when the E is qualifying for using ACE inhibitor and ARB, we will be using. So in that point of less than eGFR is 30, we definitely will not start. So the question is about in a patient who are starting ACE inhibitor and ARB in a particular eGFR, then what is the guideline to stop or continue ACE inhibitor from that eGFR? So that's what I'm trying to answer that. So when the eGFR is very low, I think we first step itself.
I mean,
we will not be starting
duration.
Usually it is, for example, if you think that it is usually it is, I'll see within a week. Within a week, especially when the patient has got a little bit of borderline renal abnormality. So I'm starting that in a patient who has got a normal renal function. I may see it after 15 days. But I'm starting on a little bit of compromised renal function. I'll see it within a week of creatinine, eGFR, and potassium. All the three we have to see and try to see. In patients who have got bilateral renal artery stenosis, this, although you have a normal creatinine or potassium, they will go exaggerated increase in creatinine and potassium. That is a clue to say whenever the creatinine is increasing tremendously or very quickly after ACE inhibitor ARB, you are supposed to suspect bilateral renal artery stenosis. So that's one condition you have to always think of when your creatinine is increasing excessively and potassium.
Now, Rajshekar.
SGLT to be given in patients.
Rajshekar, I think your internet is not good. Okay. And Tenipan, actually, you gave, somebody gave 3 drugs and then still they resistant hypertension. Last week we spoke about adherence. 50% of the people who say they are taking 3 drugs, they say they think they take 3 drugs, but when you analyze, they don't take 3 drugs. 50% of them, because of the poor adherence only, they get resistant hypertension. As usually you say, it is the drug problem, it is the patient problem, it's a physician problem. So one of the things is, they don't take, so adherence is very important in a long run. So that's why they don't get it. And they did in the Cambridge study, DOT, direct observation therapy, and found 50% of resistant hypertension is because of the poor adherence. Now, Rajshekhar, you have come back. Please go ahead. Rajshekhar?
Yes, sir.
Yeah, please go ahead.
Should the SGLT be used in diabetes with a heart failure with a preserved ejection fraction and a heart failure with a preserved ejection fraction without diabetes?
Yes, today we have the emperor preserved,
Yeah, EMPA-HF.
emperor preserved. We can use empagliflozin to the tune of 10 milligram. It's the first drug to use the reduction in the primary outcome of first hospitalization of heart failure and cardiac mortality to the tune of 17% in patients more than ejection fraction of more than 15% with signs and symptoms of heart failure, plus an elevated natriuretic peptide or a structural or a functional heart disease or diastolic dysfunction. So we can use it definitely in patient with the heart failure preserved ejection fraction. Even though the patient is non-diabetic, you can definitely use them. This is the empagliflozin of 10 milligram, which can be used in this situation. The first drug to show benefit in real HFF. The real HFF is EF of more than 15%. Many of the drugs have shown benefit in mildly reduced ejection fraction between 41 to 49%. The real HFF is EF of more than 50%. And this is the only drug now is advocated irrespective of ejection fraction. Heart failure, irrespective of ejection fraction, the one drug you can give will be the empagliflozin at this point. And of course, we are going to have deliver with a dapagliflozin. When that comes and it is going to show benefit, then these two SGLT inhibitors can be given in preserved ejection fraction.
Rajshekhar?
Sir, almost yes, answered all questions. One more question.
Yeah, what is that?
1 minute.
Yeah.
Hypertension and diabetes, that is tuberculosis and lung, needs investigation. When to start routine investigations for tuberculosis in diabetes plus hypertension, patient and risk of fungal variants and glycosuria drugs? Kindly comment.
Sir, you answer the question, sir.
Actually, I will answer. In diabetes, you should always screen for tuberculosis. In a tuberculosis, you always screen for diabetes. And as Chennaipan said, for all diabetic patients, you look for hypertension. On all hypertension patients, you look for diabetes. In fact, when you give uricosuric drugs, especially the Fowler's gangrene, especially women, SGLT to be avoided. That's what he wants to say about the anti-diabetic drugs. Otherwise, all the 3 or 4 combinations, you will have to be always monitored. But it's quite common when you get a patient with diabetes who is not under control, he may develop all sorts of infections also, along with hypertension. So what you need is proper monitoring, proper investigations, proper follow-up, and the drugs which should not be given during the fungal infection, you should avoid. That's the only thing. Insulin should be a good choice in those situations. Now,
1 minute, sir. Dr. Jayaraja has asked one question.
Okay.
So I want to answer Dr. Jayaraja.
Okay.
So we should not, we shouldn't combine beta blocker and diuretic insulin of choice, because these are the 2 drugs which will increase insulin resistance. Both the drugs will increase insulin resistance. So that's why they are not good drugs to be. And also beta blockers will increase the weight. The weight gain is with the beta blocker. Of course, this combination is primarily for this thing, but beta blocker, that's why the beta blocker and the diuretic may not be the initial choice, especially the older beta blockers or the beta blockers and also the older diuretic. But nowadays, slightly the trend may change. If you have a good beta blocker and diuretic, especially when the patient has got a heart failure, then you can start this combination. Of course, this combination is always there with either with the AC inhibitor or an ARB. Yeah. So that's what the initial drugs will not be better drugs, because they both increase insulin resistance, and also, as you know, the diuretic, many diuretics like thiazide diuretics can increase your sugars, increase your uric acids, increase their lipids, both beta blocker also. So that's why I said this combination is not the initial combination in a routine diabetes and hypertension.
Yeah. Any other question, Rajshekhar? Chenipan, if there is no question, I'll ask you. Normally, we say above 55, it is low renin, below 55 is high renin, and then you will have to give ARB, ACE inhibitor. Does it apply in a person who is elderly person, who is diabetic? Because you know whether
this is once again an elderly patient. You have to see that patient. If the elderly patient is actually is got very frail, you start with a single drug. That single drug in isolated systolic hypertension may be a small dose of thiazide diuretic, preferably indapamide, especially in patients above 80 years. You know, Hypertension study has shown a significant benefit in very elderly.
Correct.
So it's a small diuretic is the best drug in an elderly patient. If the elderly patient is preserved, that's what I told you. It is not chronological age, it is a biological age.
Okay.
The patient is 70 years, is a well-preserved patient, and is a very active, healthy person, and you are able to tolerate drugs, then you can go a little more aggressively and start giving a calcium channel blocker. A calcium channel blocker will be a better drug in a patient in elderly. As you know, it is C or D in elderly patients, A or B in younger patients. So the next drug of choice will be the calcium channel blocker, a long-acting calcium channel blocker, like a small dose of amlodipine, definitely checking about the postal hypertension and so on. That's what the combination will be. So the first drug will be, I will use the thiazide diuretic in the form of indapamide, and the BP is not getting controlled, then I add a long-acting calcium channel blocker, depending upon the patient's status, actually.
Yeah, especially in the progress trial, they use perindopril and indapamide, the trial, so they prevent the stroke in the elderly person. So indapamide is very much used, and it's also metabolically neutral. So especially when the patient has got dyslipidemia, it's a better drug. Chenipan, last question from my side is pregnancy, diabetes, hypertension. What is the target?
Less than 140/90. Don't go below 130/80 or so. So don't reduce significantly, not the target like 120 there. So it is preferable to keep the blood pressure around 140/90 and between 130/80 to 140/90. That is the ideal target in a pregnant patient. So don't reduce your pressure too excessively in a pregnant patient. If you are able to maintain around 140/90 and the recent guidelines have come to 130/80 actually in pregnancy and hypertension. So it is between 130/80 to 140/90 will be the target.
In fact, the ADA says even up to 160/90, if there is no target organ damage, you don't aggressively treat pregnancy hypertension. The ideal target should be 120 to 140. The diastolic will be 80 to 85, like that. You know, ADA says. But as you said, 140/90 should be a good rule, and then you should not reduce below 140/90 in the pregnant woman. Okay, I think we'll conclude. Let's start with Rajshekhar. You want to say anything?
One more, there was a question. Diltiazem, verapamil can be.
Diltiazem, verapamil?
Yeah, that in patients, so for patients where you cannot use ACE inhibitor, ARB in proteinuria, the older recommendation is verapamil and diltiazem.
Correct.
So today what we do is we give calcium channel blockers like benidipine, which has got some effect on actually the T channel and the L channel and the N channel. The T channel has got a peculiar effect on aldosterone. So it is supposed to reduce the aldosterone, and the benidipine has got, because of the T channel effect, it can actually constrict your afferent arteriole, thereby reducing your intraglomerular pressure and can reduce proteinuria. We have clinical endpoint trials showing that the ESRD can be postponed with the benidipine and so on. So we prefer to use the benidipine in those patients who got a proteinuria, where we cannot use ACE inhibitor and ARB to reduce the intraglomerular pressure. So that's not in guidelines, but practically we use because of its effect on T channel.
Yeah, I think Rajshekhar, any comment from you?
Yeah. Can we use diltiazem, verapamil as such? We don't use it as an antihypertensive.
Yes,
yes.
It requires a very large dose verapamil and diltiazem to get the BP under control. You cannot control with what we use as 40 milligram 3 times a day or 30 milligram 3 times a day. If at all you have to use, you must use 240 milligram of verapamil. Many of our patients will not tolerate. Anti-hypertensive effect of these drugs will be very minimal actually. So that's why it is not preferred as antihypertensives. Although the old recommendations are verapamil and diltiazem for the proteinuria, if we cannot use ACE inhibitor and ARB.
Yes,
Suppose
you're
the
right, exactly. We cannot use verapamil and diltiazem at all because, like we were talking of patients with the cardiac patients as well, we can never combine them with beta blockers. They have absolutely no antihypertensive effect. The only effect is the rate controlling and causing bradycardia. The only choice of these drugs would be in tachycardia. They have absolutely no antihypertensive role, both diltiazem as well as verapamil.
But Chenipan, if the patient has got additionally angina, is there any role for diltiazem?
So it all depends upon the patient. So first, if the patient has got angina, my first drug of choice will be beta blocker and not verapamil or diltiazem, because the beta blockers have got multiple benefits in a patient with the coronary heart disease when compared to verapamil and diltiazem. Only I cannot use a beta blocker because now that I cannot use a beta blocker is not a good statement today, because we have a better beta blockers. Yes. In many situations, we are able to use them, like bisoprolol, where the side effects are less. Even we can, bronchial asthma patients tolerate nebivolol, they can tolerate bisoprolol. So that situation is very, very rare today, where I cannot use a beta blocker because we have a better beta blockers. So these things were applied when the older beta blockers were there, where there was a significant side effects. So, okay. So the important problem with verapamil and diltiazem is the LV function. So if the patient has got a mild to moderate LV dysfunction, any ejection fraction less than 56% or even low normal ejection fraction, I never touch verapamil or diltiazem. So that's the important precaution we have to take before we start.
Negative ionotropy.
Yes.
Unless if suppose somebody has got atrial problem or tachycardia.
Still, beta blocker is better. Beta blocker is a better antiarrhythmic drug.
Okay. If they
compared to verapamil, yes.
Verapamil
in acute situation, yes. If the adenosine, you have a contraindication to adenosine, then we can give, definitely you can use intravenous verapamil. Yes. But it is rarely available now, actually, because we have been using verapamil for so many years. Correct. Or reversal of SVTs. Of course, very good drug. Most often I find verapamil looks better than adenosine. Correct. Because adenosine, all these problems are rapidly injecting, all these things are there. But we have converted so many SVTs with verapamil beautifully. Yeah. So I still have one box of old expired verapamil in me with my kids. So because we were using left and right those days, verapamil only injection. Okay, I think we'll wind up. Rajshekhar, any comment you want to make? Otherwise, I'll go to Mr. Sanjay from World Lung Foundation South Asia. Just your comment, Sanjay, about all the webinars and then Dr. Sangram sir, Sangram sir.
Sangram, yes.
Please unmute.
Yes, sir. Let Dr. Sanjay finish.
Yeah.
I want to thank all the panelists, all the participants for a beautiful set of webinars that been conducted under the leadership of Dr. Murunathan. Thank you very much all for being a part of this entire exercise. And we hope to see you again soon in the next lot of webinars that are being planned by Dr. Murunathan.
Yeah, in this connection, I am very happy to inform you, we are going to have another 5 sets of webinar series on hypertension. We'll give a gap for 1 month and then we'll start again 5 sets of webinar under the auspices of World Lung Foundation, South Asia's support. Sangram brother, your comment.
Yes, sir. My thing is regarding the basics, we have to have a regular blood pressure monitoring. We should take all the precautions, and at least once we should record the blood pressure, because most of the time we rely on the staff and all the subordinates, and maintaining the target blood pressure is important in diabetes mellitus. Selection of drug is equally important. Lifestyle modification, OSA management, and insulin resistance is very important. And game changer drug being the dapagliflozin coming in future days, and initiation of insulin itself in management of diabetes is a game changer. Thank you.
Okay, Sangram. Good sir, Sidhu. You have come for our webinar.
Yes,
Welcome.
yes, thank you. It's been wonderful sharing platform and knowledge. Everything was awesome. It was very nice. Thank you for letting me join in, and thank you very much.
Thank you, Sidhu. Now, final comment from our great teacher, Chennappan.
Sir, that the final comment is my last slide.
Okay.
Uh,
Predict,
Predict, prevent, and protect.
prevent, and protect. I
Yes.
think that slide is very good because even Christine Bernard, recently I also put the slide often. He says, my lifetime, I've saved 150 patients by doing 150 transplants. If I'm given a new chance, I would have done preventive cardiology and would have saved 150 million patients. That is what the statement by Christine Bernard. So I think preventive cardiology is very good, whatever Chennappan said. And one more good point Chennappan said was, in a hypertensive patient, 2.5 times more common, more to develop diabetes. So don't think only diabetes people will develop hypertension. Hypertension people 2.5 times more than diabetes developing hypertension. There was a recent study where they gave tablets control the hypertension. They postponed the diabetes by giving a tablet, nighttime hypertension, anti-hypertensive drug, and they prevented diabetes. So prevention is possible even in the hypertension stage. You can prevent diabetes. And in a diabetic stage also, when you prevent pre-diabetes and diabetes, you can prevent so many conditions. Again, common soil thesis, even atherosclerosis also the same soil, like diabetes, hypertension, atherosclerosis, all the three insulin resistance is the common soil. So if you prevent, if you do all the things, it will be good. Meenakshi, you have come now. Just give your comment, Meenakshi.
Yes. Sir, good evening, sir. First of all, it is always wonderful to listen to our Lord Chennappan, sir. Thank you so much for that excellent presentation, sir. And one thing I just wanted to conclude regarding this, sir, all the 5 series of lectures were on different topics, and it really helped all of us and our PG students also to learn better this hypertension in a better way, including guidelines and private sector management, sir.
Thank you, Meenakshi. Thank you, Meenakshi, because those 2 topics, new topics for us, and we've taken, and there was good response for even adherence and private sector management. So yes. I thank all the speakers from right from Chennappan, who initiated with his lucky hand first webinar and the last webinar, and then speakers like panelists like Rajshekhar, Sangram Pradar, Meenakshi Bhattacharya, and Dr. Prabhagar, all those people who joined, Sadanand Sethi from Bombay, all those panelists and then expert panelists and the speakers who are joining us in the masterclass webinar series organized by World Medical Academy and the World Lung Foundation. I will request all of you to join again after a month. We'll give 1 month break, and we'll have again series of webinars or 5 webinars again under the same banner. And those of you who attended all the 5 webinars, please send your courier address and email address. Mega already given their email ID. You send it to her. And all those who attended all the Kahoots, definitely we'll be sending you a home blood pressure monitor. And I always promote home blood pressure monitor. Please, home blood pressure monitor, you also promote, and make sure all of us together we can control hypertension, which is more dreadful disease than all the infections put together, all the non-communicable disease put together. If you can prevent hypertension, you can prevent many deaths and disabilities. With this, I thank once again all of you for participating. It's going to be now 11 o'clock as usual when Chennappan and we all are there. We can drag on and drag on. But today I reduced the questions to Chennappan because he has to catch the early morning flight to go to Udaipur. Enjoy your stay at Udaipur, Chennappan. Please, I'll ask some of them to come and meet you in Udaipur. We can conduct one webinar in Udaipur also. Thank you very much, Chennappan.
Thank you, sir. Thank you, sir. Thank you. Thank you.
Good night.
Good night.
Happy trip to Dr. Chennappan.
Good night.
Thank you,
everyone.
sir. Thank you, sir. Thank you, sir.